Good morning and good afternoon. My name is Tracy Cook, and I'm with Sachs Healthcare Communications. I'd like to show our audience today how to send in your questions, which our speaker will answer as many as possible at the end of the webinar. Our moderator for today is Jennifer Barsamian. Dr. Barsamian is a nurse specialist at Beth Israel Medical Center in Boston. She provides education, mentoring, and support for clinicians and expert consultation at the bedside for patients on 2 inpatient medical surgical units in a major academic medical center. She has published in several peer-reviewed journals on topics relating to professional development and supporting the role of frontline workers. Additionally, she has presented both podium and poster sessions at many regional conferences on nursing improvement and development. Jennifer, welcome.
Thank you so much for that generous introduction, Tracy. Today's webinar is the importance of high-quality CPR, science, and practice. And speaking on this important topic is Kenan Kunsel. Kenan is currently Global Director of Clinical Marketing at Zoll. Prior to joining Zoll, Kenan worked as a 911-based paramedic with the San Diego City EMS. Kenan has co-authored peer-reviewed studies in the field of resuscitation and has published in the Journal of Critical Care and the Journal of International Emergency Medicine. In addition to his paramedic certification, Kenan also holds a degree in mechanical engineering from UC San Diego. He maintains his paramedic license and is also certified as an instructor for ACLS, BLS, and PALS. The speaker has shared with us the following disclosures. This educational activity has been approved for 1 contact hour. A link to obtain CE credits will be available at the conclusion of this webinar. The accreditation statements are shared below, and support for this educational activity is provided by the Zoll Medical Corporation. And with that, I'm going to hand it over to Kenan.
Yeah, thank you, Jennifer, for that humbling introduction, and thank you everybody for joining. It looks like we have close to 1,000 people tuning in, which is incredible. So good morning, good afternoon, good evening, depending on where you are, and thanks for joining. So today we're going to be talking for about the next 45 minutes or so on the importance of high quality CPR. So the learning objectives and sort of what we're going to tackle today, first of all, is really trying to define the importance of high quality CPR, and tie that back to the AHA and of course their guidelines. We're going to take a deep dive into the critical components that make up high quality CPR and get into the science behind them. And then we're going to wrap up on, hopefully a positive note where we're going to talk about some ways that CPR quality can be improved, both, improved individually and then also kind of improved at an institutional level within your hospital or EMS service, with a hope of doing better CPR and ultimately impacting and improving patient outcomes, which is of course our goal. So just to sort of frame this problem briefly, sudden cardiac arrest is extremely prevalent, despite the fact that every time I watch the news, they mangle cardiac arrest and heart attacks. Cardiac arrest out of hospital, it impacts about 350,000 adults in North America per year, with survival rates roughly about 10%. For in-hospital cardiac arrest, that number is estimated to be about 300,000 per year. That's get with the guidelines extrapolation, essentially. And of those arrests, about 26% are estimated to be discharged alive. So, extremely prevalent. It's been in the news quite a bit, as many of you will realize, and hopefully we'll give you some good background info to help improve outcomes. So when we go kind of back to the AHA guidelines in 2020, their most recent set of guidelines, they really re-emphasize the importance of high quality CPR. They call it the most important single intervention during resuscitation, as well as kind of defining it in this quote as the cornerstone of modern resuscitation. So the intervention most closely related to good resuscitation outcomes. So, I'll kind of start this science-based presentation with the oldest study that I'll present today. This is a study by Paradis way back in 1990. But I start with this slide because I think it frames, the ultimate problem that we're trying to solve, and we're going to spend, essentially the next 30 or 40 minutes talking about. So obviously, if you're in cardiac arrest, you require perfusion. And so this study looked at the level of coronary perfusion pressure required to achieve ROSC, return of spontaneous circulation. And what this study found is that if you can't get CPP above 15, there's essentially a 0% chance of obtaining pulses or ROSC. If we're able to get that CPP up above 15, as you can see from that graph, the chance that we're going to obtain ROSC dramatically increases, and again, even increases if we can get that above 25. The problem is this study cited that manual CPR generates an average CPP of about 12. So hopefully you can see that problem here. If manual CPR generates an average CPP of 12, and we need at least 15 to achieve ROSC, that's why, especially back in 1990, the odds of surviving arrest were pretty low. And so really everything we're going to talk about today is focused on trying to raise the level of perfusion during arrest with the goal of achieving ROSC and, survival and neurologically intact survival ultimately. So the AHA defines CPR quality pretty specifically. The rate is defined to be or should be between 100 to 120 compressions a minute. Depth for adults, which is what we're going to focus on today, is between 2 and 2.4 inches. For the rest of the world, that's 5 to 6 centimeters. A full recoil or coming off the chest completely during each compression, which we're going to talk a lot about. Chest compression fraction. So chest compression fraction is the percent of time during an arrest in which compressions were performed. So basically it represents the frequency and the duration of pauses. And so the idea is we want to be on the chest doing compressions, as much as possible during the arrest. The goal again is as high as possible. They describe a minimum being 60%, above 80% may be achievable. And there's some studies showing that even 90% is achievable. And then pauses and pulse checks. Again, we're trying to minimize pauses during compressions, but they should last no longer than 10 seconds. Ventilations we're going to come back to in a little bit, so I'm going to skip that portion for now. And then we are going to talk about a few sort of miscellaneous topics tied into high quality CPR. The first is end-tidal CO2 and continuous capnography during resuscitation. The second is debriefing. And then we're going to talk a little bit about real-time CPR feedback, both for training and during live resuscitation. So, before we start, there's a whole bunch of studies on this topic. I just sort of chose one as a bookmark to make sure I discussed it. But, there's an overwhelming majority of us clinicians that believe we do really good CPR. But the fact is, when it's measured and we can objectively kind of test that theory, that we don't. And so this study actually looked at over 80 clinicians that regularly perform CPR. The majority of them actually couldn't even define high quality CPR, in the way that we just did per the guidelines. And then when they were tested on their abilities, they overestimated them significantly. So the study really went on to look at how much they improved with feedback. We'll talk about that a little bit later. But really, there's so many studies out there that as clinicians, we absolutely overestimate our ability to perform high quality CPR. So as we get into more specifics here of chest compressions, we'll start off by talking about chest compression rate and look at a couple studies behind that. So the rate obviously is prescribed by the AHA as 100 to 120 compressions a minute. These are two different studies done by Idris and his colleagues that looked at chest compression rate as it relates to survival. And so that graph on the left, you can see chest compression rate is a nice Gaussian curve, sort of bookmarked at 100 to 120 chest compressions per minute. And you can see survival is pretty clearly the highest, about right in the middle at 110. And when they published again a few years later, similar outcome, 100 to 120 compressions a minute showed the highest level of survival to hospital discharge. So, before the guidelines changed in 2015, the 2010 guidelines, I believe, said chest compression rate of at least 100. And so for a lot of, paramedics and folks like me, we almost took that as like a challenge to see how much faster than 100 we could go, which is unfortunate, after looking at this data that was published subsequently. So this idea of 100 to 120 is, strongly founded in science and directly relates to probability of survival. So, essentially it's really important to make sure you stay in that range prescribed by the AHA. So kind of along the lines of like the olden days when we used to do 140 or 150 compressions a minute, obviously if your rate increases kind of beyond 120, 130, 140, it's essentially impossible to maintain the proper depth. And so this was a study in 2012 that basically showed that as your compression rates increased, your depth decreased. It doesn't matter how strong you are, how many push-ups you can do. It's just inevitable. And, I really think this study is important because we're going to talk quite a bit about these different specific areas of high quality CPR, like they're separate, but a lot of them are intertwined. And this is a perfect example of how rate affects depth, depth affects rate, and so forth. So they are related. So if we move on to depth, so this was, the first study that came out of the Resuscitation Outcomes Consortium group on the topic of depth pertaining to survival. So this was 2014, and they showed that maximum survival occurred at depth right around 5 centimeters or 2 inches. It was worse if your compressions were too shallow, and it tailed off again if your compressions were too deep. And so this was one of the big studies that informed the guidelines that looked at this 2 to 2.4 inches. Subsequently, this was just a couple years ago, another study came out looking at the same thing, compression depth and the probability of survival. And this study directly tied compressions between 2 and 2.4 inches to a higher probability of survival. So, this idea of being able to do compressions between 2 and 2.4 inches is sometimes, sometimes you see eyes roll like that's an unrealistic expectation. However, it's so important, as the science shows us, that if you're outside of that range, the science shows us that the chances of survival are, diminished in either direction outside the guidelines. And then one study, this was referenced by the AHA in 2015. This came out of the Nordics. It looked at the rate of injury during chest compressions, specifically chest compressions that went deeper than 6 centimeters or 2.4 inches. And this was a really interesting study in the way they broke out male versus female patients that probably don't have time to get into today. It's really interesting. But essentially what they found was that if you go beyond 6 centimeters of depth or 2.4 inches, you greatly increase the risk of sternal injury. So between the science showing 2 to 2.4 being better for survival and then beyond 2.4 increasing injury, that's where we've landed at our small window of appropriate depth for adult chest compressions. So, we've talked about rate and depth. One of the hot topics in the world of resuscitation is recoil. There are a number of, esteemed researchers that are thinking that recoil is, as important or maybe more important of a metric than rate and depth. So let's take a little bit of a dive into the science here. So this study is always a little bit tricky to explain. I'm gonna take my best shot. If we need to come back with questions, we can. But basically, this study by Yiannopoulos and his colleagues looked at the impact of leaning on the chest. So the graph on the left is coronary perfusion pressure, so the heart. On the right is cerebral perfusion pressure, so obviously the brain. And each one of those graphs shows basically 3 chest compressions in a row. So that first chest compression that shows 100% means that there was no leaning done, 100% decompression. And you can see for the heart and the brain how much perfusion was achieved. So that second compression, the patient, the decompression percent was only 75, which means there's a 25% lean on the chest. And you can see both heart and brain blood flow decrease significantly, as you'd expect. But then what's really interesting is that that third compression was back to no leaning, 0 leaning, but the blood flow to, again, both the heart and especially to the brain still did not increase to original levels. And so what this really goes to illustrate is that if you lean on the chest, you really get punished, twice for every 1 mistake. The compression that you lean on is not optimal in terms of perfusion. And then that next compression, even if the next compression is perfect, is compromised as well, just because the heart didn't flow or didn't fill up with blood. And so by leaning on the chest, you set up this kind of cycle of poor perfusion, which makes it just really, really important to not lean. This was a study that shows a similar sort of overall point. This was looking at cardiac index and myocardial blood flow throughout an 18-minute resuscitation. And so early on in the resuscitation, when there was no leaning, you can see that the flow was extremely high. About 4 minutes in, they started leaning on the chest, and you can see how dramatically that reduced blood flow. It reduced even more as they continued to lean throughout the resuscitation. And then that last 3 minutes, they actually went back to no leaning. But again, just like the last study, we couldn't recover essentially. So leaning on the chest just again sets up this sort of vicious cycle of not perfusing well and not being able to easily recover from that leaning on the chest. So so we talked about rate, depth, and recoil. And if we peel back another layer, there's yet another topic here. So this is the idea of release velocity. So what we just talked about was essentially if you compress 2 inches on the chest and release those full 2 inches, then you're not leaning. That's full recoil. But release velocity is release velocity is the speed in which you're coming off the chest. So not the distance, not whether you're doing it fully, but how quickly you're allowing the chest to recoil. And that metric, chest compression release velocity, CCRV, was shown by Kovacs and a group of his, including Ben Bobrow, to significantly increase survival to discharge just by releasing off the chest faster. So they broke the results into 3 groups, basically slow release, moderate, and fast. And as you can see by those graphs on the right, the faster you could come off the chest, the faster you can recoil, the better the odds of survival. So, this just goes to illustrate, as much as we'd like to think that CPR is really simple and, maybe put like the brand new clinician on the chest so we could do all the other maybe more exciting things. The most critical part of resuscitation is chest compressions, and it's hard to do good chest compressions. So a colleague that I respect quite a bit that chairs a pediatric resuscitation program at a big hospital near me has started teaching their clinicians to think about the heart and the brain every time they push and release off the chest. So literally they're trained to, as they're doing compressions, think heart, brain, heart, brain, heart, brain as a sort of means to be more deliberate about making sure they come off the chest. So chest compression fraction, we talked a little bit about this, the percent of time during an arrest in which chest compressions are being performed, which essentially is just a comprehensive measure of pauses during an arrest. So in general, pauses are bad. Sometimes they're essential, but the idea is when they're essential, we have to try to keep them as short as we can. So this was a study by Donna Edelson that looked at the impact of pre-shock pause time. So this is the pause time that occurs, right before a shock is delivered. And so they were able to find that shock success is directly correlated, like near inverse relationship between pause time and shock success. So if you can keep that pre-shock pause time under 10 seconds, the shock is 94% likely to be successful. And if you start delaying that out to 20 or 30 seconds, you can see how rapidly that shock success decreases. The physiology around this is super interesting. It's out of the scope of today's lecture, but really interesting in terms of shock success and pre-shock pause times. And to take it 1 degree further, so Dr. Cheska's up in Canada published a study that looked at the impact of pre and post-shock pause times on survival. So not shock success, but actually through to survival. And what they found was that pre-shock pause times less than 10 seconds and peri-shock pause time, and peri-shock means the combination of before and after the shock, when that cumulatively was under 20 seconds, there was a significant improvement in hospital discharge. So, just one of the pauses during an arrest is likely going to be around defibrillation. So the pre and post shock pause times, like all pauses, are really important to try to minimize as best as you can. So ventilations. So one of the things that has kind of started to drive me a little crazy over the last few years is kind of hearing chest compressions used interchangeably with CPR when they're different. So, chest compressions are what we just talked about, literally pushing on the chest. But CPR includes the P, which is the pulmonary component, or ventilation, which is actually really important as well. And so I skipped this back at the beginning. We'll dive into it now. So the AHA recommends a rate for adults of about 10 breaths per minute with an advanced airway, or 30 to 2 without, and the tidal volume of roughly 500 to 600 mLs. And there was a mention of a duration in the guidelines as well, about 1 second duration. And I'll show you some interesting studies around that. So the study by Afterheide back in 2004 looked at it was a pig study that looked at the effects of hyperventilation in coronary perfusion pressure. So they ventilated these pigs at 12, 20, and 30 ventilations a minute. And you could see that coronary perfusion pressure dropped as that ventilation rate increased. And interthoracic pressure, which is really the enemy during an arrest, basically decreases venous return, venous blood returning to the heart, actually increased. So we had what we wanted to raise goes down, what we don't want to raise goes up as an effect of hyperventilation. And you could see that 24-hour survival on the right was dramatically better with normal ventilation rates versus that hyperventilation at a rate of 30. Unfortunately, I think we're all guilty during resuscitations of hyperventilating patients. So this was a study from 2007 that looked at ventilation quality in adults in a hospital setting. So that mean ventilation rate was 21, instead of 10, which it should be. Not only was the rate too fast, but we were squeezing the bag too hard, essentially. So too much tidal volume, which meant that our minute volume was way over the AHA's guidelines, AHA's recommendations. This next study shows really the same for EMS. So for EMS folks, you don't get away so easily either. The results were almost the same. Median ventilation rate was 20, and 90% of patients had ventilation rates above the guideline recommendations. So roughly twice as fast as what we should be aiming for. So that's rate that we've talked about, right? Ventilating the patient too quickly. The next interesting piece is to look at duration. And so one of the things that I've seen happen a lot is that when a patient is being hyperventilated like you can see in that example on the left, a rate of 38 breaths per minute, and you try to coach a provider to slow down, they'll slow down their rate, but they'll prolong the duration. And so that box on the right shows a rate of 11, but they're ventilating for about 4 seconds per breath. And that is unhelpful during an arrest because, as mentioned there, it leaves little time for the development of negative interthoracic pressure. Again, that helps with venous return. So, you know, when you're thinking about rate and maybe coaching a colleague to slow down, just make sure that they don't end up slowing down but squeezing the bag for longer, which is harmful as well. And lastly, with ventilation, sort of the last component, we talk about rate and duration. The last piece is tidal volume, which is essentially, you know, the depth of ventilation. And you know, this graph is a little bit of an eye chart to look at, but essentially showed in 2021 the study that ACLS providers were basically all over the place in terms of tidal volume delivered to patients. It ranged from, you know, in the neighborhood of 100 mLs all the way up to right at 1,000. A few providers were able to get their tidal volumes in the right range, but it, you know, it was all over the place with the same, you know, 1,000 ml bag. So, you know, something to be really careful about with, you know, watching for chest rise and fall, or sort of targeting this this target of roughly 500 or 600 mLs. So the topic of CO2 is a really interesting one. It's another hot topic during cardiac arrest. So it's an AHA class 1 recommendation for verification of tube placement. You know, that's the highest recommendation that the AHA gives. It's class 1, you know, essentially standard of care. And then they give a class 2B recommendation for using CO2 to both guide CPR quality and to detect ROSC. So the guiding CPR quality piece is really interesting to me because, you know, if you have a compressor who's doing compressions and you watch the CO2 on a patient sort of drift around 12 or 15, and you switch compressors and that CO2 drops to 8, you know, it's probably a pretty good indication that those compressions aren't the same quality as the person who just got off the chest. You know, that drop in CO2 obviously won't show you specifically what the issue is. You know, is it rate or depth or recoil, or, you know, potentially even could be a change with a patient or a change with whoever's ventilating, but at least alerts you to potentially a problem that could be corrected. So, you know, it's really interesting to be used in that way. And then detecting ROSC is another interesting one. You know, there are definitely resuscitation programs that have made the decision that they're not going to stop to check pulses until CO2 jumps to, you know, above 20 or above a predetermined rate. Because, you know, if you're doing chest compressions and you have a patient who's consistently at 10 or 12, it probably doesn't make sense to stop for pulses because they probably don't have ROSC with a CO2 at that level. So, you know, this could be a lecture in itself. There's all sorts of interesting capnography waveforms, which you can see in that screenshot, tied to all sorts of different clinical issues. But for the topic of resuscitation, that's sort of a broad brush. Again, using it for detecting ROSC, first of all, and then to help guide CPR quality, along with obviously a verification of tube placement. So that was the real deep dive into the science behind CPR. And so where I wanted to focus for the last 10 or 15 minutes was, you know, kind of taking all that information and then providing a little bit more of an optimistic view on how we can do a better job providing CPR, again, both individually and as a system. And we're going to finish up with some examples of resuscitation programs around the country who have been able to impact patient outcomes using CPR as, you know, really the cornerstone. So the first topic from the 2020 guidelines, and this primarily came out of Betsy Hunt and her group, Johns Hopkins, was this idea of a CPR coach during a cardiac arrest. And so the AHA has a suggestion in here of a specific role during an arrest that acts as a CPR coach, which seems to make sense. You know, if we think CPR is the most important intervention during an arrest, we can have a person at an arrest that, you know, maybe can bring in and operate the defibrillator, but acts as a CPR coach throughout the arrest, you know, coordinating compressor switches and things of that nature. So obviously this depends on your system and the sort of personnel available, but it's certainly something to consider in terms of roles and responsibilities, to have somebody dedicated to making sure that high quality CPR is being done throughout the arrest. Probably not personally doing it again, but overseeing it as sort of a, you know, an adjunct to the team leader or the code leader. So CPR feedback, so the idea of having coaching or real-time coaching during an arrest is a Class 2B recommendation now from the AHA. It may be reasonable to use audio-visual feedback devices during CPR to optimize CPR performance. And they say the use of real-time audio-visual feedback is suggested as a means to maintain CPR quality. So there's a couple studies that sort of address this issue of CPR quality and what potentially can be achieved. So this one was by Ben Bobrow and his group out of Arizona. And so they looked at so within this EMS service, they had a period of time in which they had defibs out in the field that were just collecting CPR data and not providing any feedback. And so essentially these crews were coached to run resuscitation just like they always had, but had a you know, a means to record the quality of their compressions. And then after sort of drawing a line in the sand, everyone was brought in for a short training, a few-hour training, where they had a, you know, lecture similar to this one on the importance of CPR, and, you know, did some, you know, obviously some training and some practice with a device, and then were sent back out armed with CPR feedback during their arrest. And so what they were ultimately able to achieve was an improvement in survival, in overall survival. So their odds ratio was nearly 3 times. They had nearly 3 times the odds of survival in the CPR feedback group than they did without feedback. And this next slide here is an example of an actual case both before and after the implementation of that training and feedback. So that case on the left, if you look at that compression depth chart, you can see that you know, almost none of those compressions during this 30-odd minute arrest were done deep enough. All of those kind of gaps between those dark blue bars are pauses. So there were many long pauses during this resuscitation as well. So their compression fraction was not great. If you look down at rate, very few compressions were within that 100 to 120 compressions per minute. In fact, a lot of compressions are actually like clipped off that screen because they're at a rate of above 140. So shallow compressions, fast rate, low compression fraction, long pauses. And then if you move over to case 2, you know, survivor this time with feedback, you can see the chest compressions were much more consistent. Most of them got into that 2-inch depth range, much shorter pauses, you know, more consistent rate. So overall, you know, just much better CPR. And so this study on the impact of real-time feedback on compression quality was, so I had the privilege of being part of the study. And so without getting into sort of the complexity of it, essentially what was found is that with 2015 guidelines, in a sort of mannequin simulation setting, clinicians improved from 16% compressions in target to over 90% compressions in target with CPR feedback and just a couple minutes of coaching. And sort of on the ventilation side, a similar story. And so there are means now of having real-time feedback for ventilation quality, so both rate and tidal volume. And so this was a study done just a couple years ago, published in Resuscitation Plus, that looked at the impact of real-time ventilation feedback in a simulated EMS environment. And so you can see that rate increased dramatically with feedback. Correct tidal volume was the biggest issue, and it increased almost the same amount. And then overall correct rate and tidal volume increased from 9% in target to 91% in target with feedback. So, there are clinicians that can perform good chest compressions and good ventilations with no feedback. I think the biggest problem is everyone thinks they're that person, until they're actually measured. And even the folks that do it well, it's hard for them to do it consistently. So real-time feedback for both ventilation and CPR quality is, I think is critical. The next topic we'll dive into just for 2 slides is this topic of debriefing. And I think it's important to define debriefing in a different way than, my days as a clinician, where we'd sort of be asked how we thought it went, and we'd all say it went great, and we did the best job, we did perfect compressions, but there was no data to back that up, to either prove or disprove it. And so really the verbiage, I think, has changed. The AHA calls it performance-focused debriefing. The ERC over in Europe talks about data-driven debriefing. But it's this idea of not just looking at, how do you think it went, how is communication, and these sort of more soft skills, but also looking at performance in terms of, CPR metrics, compression depth, compression fraction, ventilation quality, and those types of things. And so in short, the AHA has this as a class 2A recommendation now, performance-focused debriefing after cardiac arrest with objective and quantitative data. And so the 2 studies that really informed that recommendation, the first was Donna Edelson again, that showed an improvement in ROSC rates after they implemented their debriefing program. And then that study on the right was Heather Wolf and her colleagues out of CHOP. So, obviously a highly acclaimed pediatric hospital, but just by implementing a data-driven debriefing program, they were able to improve survival to discharge and survival to discharge with good neurostatus massively. Again, just by implementing this data-driven debriefing program. So, I think hopefully that's inspiring. It wasn't a secret medication or sort of any fancy treatment. Literally just implementing this data-driven debriefing program had a real impact on survival in this big pediatric hospital. So, sort of the last topic we'll get into before we take time for some questions is this idea of a systems-based approach. And so, as much as this lecture is about high quality CPR, I think it is important to zoom out a little bit and look at this sort of chain of survival from the AHA. Obviously, high quality CPR is a link in that chain. It's in purple there on both the in-hospital and out-of-hospital arrest. I stand by and agree with what the AHA claims is the single most important intervention, but it's not the only intervention. And so, especially in 2020, it seemed to be a kind of shift in language more toward a system of care, a system-based approach, system saving lives, and this idea that it's not any one intervention on its own that's going to have a massive, improvement in survival rates. We really have to look at all of the links in the chain and strengthen all of them. So, the easiest example is if you show up as an EMS provider to a nursing home at 7 in the morning and have a cardiac arrest where you provide the best high quality CPR that's ever been done in the world, but that patient had been dead for some time, there, basically the failure in that case was early recognition and prevention. It doesn't matter how good your CPR is, the outcome is, relatively inevitable. So along the lines of the system-based approach is the question of, does a single therapy impact survival? So I showed you a couple examples, where a single therapy did impact survival, but there's some sort of mixed studies out there about changing one thing in a resuscitation program and not having a big impact, because again, it's about the systems-based approach. The cornerstone of resuscitation is absolutely high quality CPR, but the AHA talks about a system-wide approach at every level of care, from prevention to recognition to treatment, is essential to achieving successful outcomes after arrest. So I'll leave you with two specific examples of systems that have been implemented, one in hospital and one in EMS, where they've implemented a system to improve resuscitation outcomes and have seen pretty dramatic results. So the first is near my home in San Diego. So this is the Advanced Resuscitation Training Program that was Dr. Dan Davis and UC San Diego. And so they implemented a resuscitation bundle, is what they termed it, with the goal of improving outcomes from in-hospital cardiac arrest. So they had a big focus on prevention. They overhauled their training. They implemented CQI and data and debriefing. And then also, like we talked about, this cornerstone of CPR feedback and training and a real push to improve CPR quality. Their CPR algorithm that they developed is, I love it. It's so simple. Dr. Davis teaches these programs, and that box around CPR that you could see on the right, they teach as CPR Island, with this idea that when you're on CPR Island, you're safe. And if you need to leave CPR Island for any reason into these shark-infested waters surrounding the island, you better be quick. And so they teach that if you have to pause for defibrillation, it should be as quickly as possible, with strategies to impact that. Their pulse checks are tied to a CO2 of at least 20, like we talked about, so they won't stop for a pulse check unless they have a CO2 of greater than 20. Ultimately really trying to minimize pause times. And in this study, they showed a compression fraction on average of above 90%, which is absolutely incredible. So with this program, they were able ultimately to improve survival from cardiac arrest from 21% to 45% over the period of the study. They tripled neurologically intact survival, and they were actually able to show a reduction in overall hospital mortality as well. So, some really phenomenal results in terms of what they were able to achieve through this system, kind of built around this idea of high quality CPR. And from an EMS perspective, this was Salt Lake City Fire Department. They published this in 2016. So they implemented this resuscitation bundle that included real-time CPR feedback, debriefing. They changed their algorithms and simplified them, integrated this pit crew CPR approach that we talked about, and a number of other things as well. And what they were ultimately able to do was more than double functional survival to hospital discharge. Survival to hospital discharge increased from 11 to 17%. So, again, some really impressive gains in terms of survival as a result of, this resuscitation program, again, with CPR as sort of the foundation, but that address these other links within the chain of survival that they could control. So what I'll leave you with before we move into some questions is a quote from the AHA and their consensus statement on CPR quality. So as the science of CPR evolves, we have a tremendous opportunity to improve CPR performance during resuscitation, both in and out of the hospital. Through better measurement, training, and systems improvement processes of CPR quality, we can have a significant impact on survival from cardiac arrest and eliminate the gap between current and optimal outcomes. So, really what I want to leave you with is, hopefully you learned quite a bit about CPR and the science behind it, maybe an appreciation for how complex a task it actually is. Hopefully some tips and tricks to be able to improve, both on a personal and a sort of institutional level, and some motivation that I hope you can take this back to, wherever you work with maybe a plan or some excitement around, seeing if we can improve this. And again, taking from the AHA, have a significant impact on survival from arrest and essentially improve outcomes to the point that we know they can be with all of these components in place. So with that, I'm going to turn it back over to Jennifer.
Thanks so much, Kenan, for a truly informative presentation. I'd like to tell everyone how to obtain your CE for today's presentation. This activity has been approved for 1 contact hour. You can go to www.saxetesting.com/REV and register on the test site. Once you complete the evaluation form and successfully submit it, you'll be able to print your certificate of completion. Support for this educational activity was again provided by Zoll Medical Corporation. An archive version and an on-demand version of this training will be available on www.revive-now.org. The on-demand version will be accredited for nurses and respiratory therapists. And with that, we're going to move on to some questions. Kenan, we have a lot of really great questions for you on a number of portions of your presentation today. I wanted to start out with a question about CPR training. We had a question about a movement within resuscitation training programs to pivot to a quarterly training schedule as opposed to the biannual model that has been used historically. And do you have any opinion on that or information about the sort of instinct to change to that model?
Yeah, I think, so the AHA has rolled out a program that I think is being referred to, right, where instead of kind of testing every 2 years, you test more frequently. So they have like a cart that they push around and you can do chest compressions on it and sort of tests you on the spot and extends your certifications. There's just a lot of evidence that the more often that you can train, the better. And so I think that's sort of my overall view is the more often you can practice compressions in any form, the better. There's just a lot of evidence that skills degrade just more quickly than we'd hope they ever would. And so, this idea that you 20 months ago on your day off that you went in and did compressions for like 30 seconds and like now it's 2 a.m. and you're expected to do chest compressions again, like between 2 and 2.4 inches, and like all these things we talked about that you may or may not even remember. It's much better to, to practice frequently. I'll add, there was one study that was done, I believe it was out of CHOP again, where they basically did some training like just before the shift. I think they called it just-in-time training. So just before the start of the shift in their PICU, I believe, they took all their high-risk patients, pulled all the nurses and doctors aside, and ran them through like what to do in case your patient arrests today, just in a few minutes. And they had some pretty impressive results in terms of like how that helped, right? So I guess, yeah, maybe that's the overall answer is the more training, the better.
A lot of folks were sort of interested about your data around release velocity and chest recoil. And there were a couple of questions around hand placement and hands off the chest and whether allowing for that full fast recoil requires a change in sort of the way that we've historically positioned hands.
Yeah. That's a hot topic, so I have to debate, how far I kind of wade into that one, right? So the AHA doesn't really take a stance, other than some sort of general language about like one hand on the other in the center of the sternum. But that's, astute, I'd say for sure. Like a lot of the stock, it's an astute question. A lot of the stock images in that presentation showed this sort of idea of like encircling one hand in the other, where you kind of wrap your knuckles in. I almost kind of issued a disclaimer that those are stock images and not endorsement of a particular style of holding your hands, because there's a lot of different opinions. But, for instance, at UCSD, as part of their art training, they developed a method called credit card swipe compressions, where they actually would like kind of remove the palm of their hand off the patient's chest enough to swipe a hypothetical credit card underneath, right? And, like literally create a gap between the palm of your hand and the sternum during each compression. And if you do that, the idea is you can't be leaning because your palm's not on their sternum, And so there's not a, from the AHA's perspective, there's not a sort of hard stance on it, but there definitely are different views. I think it's an area to watch for sure. There are some techniques where you come completely off the patient's chest between each chest compression. They're fairly controversial, and some people love them and some people don't. But from what I've seen, methods like that definitely have the potential to improve release velocity and release. So yeah, I love the question, but I think that's the answer for now. Is stay tuned for more sort of specific guidance.
That's great. We also had a number of folks asking if there's any data around the use of a mechanical compression device or a mechanical CPR device.
Yeah, so, pertaining to AHA's guidelines, right? So the way they sort of break it out is that they give a class 2, so it's a 2B recommendation for use of mechanical CPR devices in certain settings. And they describe it as like settings where it would be difficult to perform CPR. And so, basically the AHA says, may be reasonable in you think about like an EMS service where like they're trying to do compressions in the back of a moving ambulance, like that'd be a great example. From the hospital side, where I've seen it used to great effect is like prolonged arrests, like a hypothermic arrest, right? When there's going to be 2 hours of chest compressions that are needed and no one wants to do 2 hours of compressions, you can put on this device and just hit go, right? And potentially change a battery or two. The AHA says routine use of those devices, they have it as a class 3, which is essentially like not endorsed. I think, really how the AHA makes their recommendations though are based on levels of evidence, science essentially. And so when you take mechanical devices, and there's all sorts of them out there, the studies are relatively mixed. And so from AHA's standpoint, I think that's a reasonable view to take, is that, it's a 2B recommendation in those certain circumstances. What I would say though is that there's a number of resuscitation bundles, kind of like we talked about at the end, that implement mechanical CPR as the means to achieve high quality CPR, and have seen really impressive results in survival. And so those typically don't, they don't help from a purely scientific perspective, because they, an EMS service will implement a bundle and they'll change 12 things at once. And one of them is mechanical CPR, and they'll show improved outcomes. But from a scientific perspective, like you can't say what did it or didn't, And so, I think it's something worth looking into for sure. Like if, mechanical compressions can do high quality CPR for sure. And so, instituting that into a bundle of care, I think is totally reasonable. And there's a lot of folks that have done that. But again, just want to be clear from an AHA perspective as well, what they say on it.
That's great. Thanks so much, Kenan. We have a question from Dana about, is there any recommendation or guidance about how to begin initiating the role of the CPR coach into code situations, in terms of how folks can be trained to competently do this, and boosting folks' confidence in providing that feedback with their peers?
Yeah, that's another great question. I think it's hard for the AHA to sort of prescribe that in the guidelines, which are already so long, and very few people candidly like read it front to back, right? So, and because it has to be sort of one size fits all, it's hard for the AHA to say you should do it this way or that way. It really depends on you know, are you an EMS service or a hospital? You know, is it a critical access, you know, tiny hospital or huge flagship medical center with tons of resources? So the AHA doesn't really give specific guidance outside of like just a little bit of general information. But there are ways to do it for sure. I think that, you know, in my mind, the way they've written the CPR coach role into the guidelines to also be in charge of the defibrillator is sort of tied to a lot of defibrillators having CPR feedback. So it just makes sense to for the person who's like hitting the shock button to also be looking at the defib, which is telling you how you're doing for rate and depth and so forth, and communicating that, you know, to the compressor. You know, maybe watching CO2 like we talked about, and if you see CO2 dropping over the course of a couple minutes, you know, maybe it's a good time to swap compressors, right? It means that they're probably getting tired. So, you know, I'd love to take half an hour kind of talking about a lot of the different strategies, but I generally say that it doesn't need to be overly complex to start with. You know, even if you don't have access to any of the fancy technology, just sort of being informed about leaning and, you know, those sorts of things, like you could start to look at somebody across the room and know that, you know, when there's sweat dripping off their nose and you can see they're not coming off the chest, you know, I'd encourage somebody to be a CPR coach, you know, formally or not, and sort of try to transition compressors out and get somebody else on the chest, you know, for the benefit of the patient. So
Absolutely.
yeah, so that's a quick swing at that one, but
Mhm. This one is a little bit more technical of a question. A number of people were commenting on the fact that we have a lot of technology available to really measure some of these metrics in the middle of an active code. In particular, people were sort of curious about whether there's a way to really effectively quantify tidal volume during a resuscitation outside of a simulation, and whether people are obtaining that information and acting on it mid code.
yeah, I mean, without getting too much into like specific technology, you know, like I mentioned at the beginning, I work for Zoll, and there is technology that we have that measures tidal volume and rate in real time and provides that feedback. You know, it's available on some of our devices. So, you know, the short answer is yes. You know, you could use that and then subsequently use the data afterwards. So I think just like compression quality data, I think a lot of times people get caught up, you know, there's absolutely a benefit, like hopefully I showed that in having real-time feedback, but I'd say half of the benefit is having the data for later, you know, and using it as part of a quantitative, you know, feedback loop or feedback system. So, but yes, you know, there is that feedback available in real time. You know, if you don't have it, I think it can be something that could be focused on during trainings and that sort of thing. And even if you don't have any of that fancy technology, I think, again, if you start looking at somebody who's like just wringing every cc out of that like gigantic bag into like a tiny patient during a rest, is like you could hopefully give them a little elbow and say, you know, I think you're good.
Absolutely. Um, I think right now we're really at a moment where resuscitation is really at the forefront of the mind of the general public. I'm talking specifically about Demar Hamlin and the Buffalo Bills, sort of his recent cardiac arrest. Is there is there something that we can sort of take from this moment to sort of really increase the knowledge of the public around resuscitation? Like, how can we seize on this moment to really move things forward?
Yeah, like that's sort of what I was alluding to earlier on when you know, I almost want to like throw something at my TV if I see another update on his heart attack. You know, like I think a big piece of that is just awareness and education and trying to help people understand what happened. You know, first of all, and then the fact that, you know, CPR was started so quickly. You know, like we were talking about offline, is just, I mean, you never want a cardiac arrest, right? But if you had to have one in a situation where somebody, you know, recognized what was going on and started compressions, you know, got an AED on scene that quickly. I think that's the opportunity for the educational piece is like the awareness on like what happened, what it is, and what to do, because you know it's anecdotal, right? But I think a huge part of that, you know, so far that very positive story is the intervention, you know, and the rapidity of it. So
Absolutely.
yeah, I've had talks with, you know, my wife and neighbors and all sorts of people that ask that same question.
Mhm.
So yeah.
That's great. I think it's a great opportunity for us all. And thank you so much, Kenan, for all of this great information. I just want to hand things back over to Tracy to wrap up today's session.
Thank you, Jennifer, and thank you, Kenan, again for such a great presentation. We'd also like to thank everyone for attending today's webinar. Please note immediately upon the conclusion of this webinar, you'll be presented with an online survey. Please keep your web browser open, and we appreciate your feedback, as well as the CE Certificate of Completion. In 1 hour following the conclusion of this webinar, you will receive an email with instructions and this link to obtain your CE credits. For nurses and RTs, that's www.saxtesting.com/REV. And again, we'd like to thank everyone for attending today's session, and thank you, Kenan, for this valuable information. Have a great day.